Hello, I'm Adam Davis, and I'm an endocrinologist at the Medical College of Georgia, and I'll be presenting our case of medullary thyroid carcinoma associated with a rare RET proto-oncogene mutation, p.K666N. So, of course, medullary thyroid cancer is rare among thyroid cancers. However, it is responsible for a much larger proportion of thyroid cancer deaths. And for this reason, it is important that cases be detected early if possible, and our case illustrates this. Our patient is a 41-year-old man with past medical history of hypercholesterolemia who presented to establish care after having abnormal genetic testing. His 72-year-old mother, who has a history of breast cancer, had genetic testing performed, and this testing showed a RET proto-oncogene mutation. For that reason, our patient had genetic testing, and he was also found to have the same RET proto-oncogene mutation, which is p.K666N. He had biochemical screening for medullary thyroid cancer with calcitonin and CEA levels, both of which were normal. He had a neck ultrasound, which was also normal with no thyroid nodules. He had screening for pheochromocytoma and hyperparathyroidism, both of which were normal. He had a prophylactic total thyroidectomy, which showed a 0.2 centimeter focus of medullary thyroid carcinoma on the right lobe of his thyroid. And figure 1 here shows the pleomorphic nature of these nuclei, which is, of course, abnormal and consistent with carcinoma. And figure 2 shows calcitonin staining of the same specimen, showing positive staining for calcitonin, which is, of course, consistent with medullary thyroid carcinoma. Thankfully, there was no evidence of angioinvasion or lymphatic invasion or extrathyroidal extension. Ki-67 labeling index was only 1%, and the only lymph node which was obtained was negative for carcinoma. So our case illustrates that early detection of medullary thyroid cancer is important, and specifically early detection of patients with MEN2. Our patient's genetic screening allowed him to get a prophylactic thyroidectomy while the medullary thyroid carcinoma was limited to his thyroid. This case also adds to the available literature for this rare mutation, p.K666N. There have been 12 cases of medullary thyroid cancer which have been published in patients with this mutation, and they have a variable disease course. Only one case of pheochromocytoma has been reported, but this was in a patient who was homozygous for the mutation. Additionally, it appears that primary hyperparathyroidism is rare in this mutation, with only one case being reported. So again, our case highlights the importance of doing genetic screening in patients who are at risk and proceeding with prophylactic thyroidectomy if indicated, even in patients with negative biochemical screening. Thank you for your attention.